if it comes to prevention strategies, basically there is a high risk versus a population approach. If you have a high risk approach, according to Jeffrey Rose, you truncate the high end risk end of the distribution. If you have the population approach, you reduce risk, a little risk in most people by trying to shift the entire distribution to the right side. Now, like I just said, if you try to address the entire population, you may want to question yourself what this means for public health and healthcare. Well, you probably, as a public health clinician, you tell the public to move more, to do sports, exercise, physical activity. Now, the key question is, and that was my issue about contextual pressure, can people really do that? To what extent can people voluntarily and lifelong change their physical activity behavior? If you tell someone to implement a sports injury prevention measure or to become physically more active, you basically tell them to change their life. And then the key question is, to what extent can people voluntarily, lifelong change their physical activity behavior? How realistic, because this is then what you would like to say, how realistic is the solution of self-regulation and self-responsibility? You are confronted with these kind of patients in your consultation room, and it's troublesome. Now, here is one of the trials that we've done in the workplace, where for 6 months, we have actually been trying to get people physically more active. And what you see from this graph, and this is the difference between the telephone-based and an online-based intervention against care as usual, and the red is the telephone group, the internet group, and the blue is the telephone group. You see that compared to the care as usual, there was after 6 months a decrease in body weight, but then in the year and a half to follow up, you see that slowly creeping back. And this is also, in my opinion, one of the demonstrations that people can't self-regulate and that environmental pressure, contextual measures sort of take over. Another example was the Dutch obesity intervention that we've been doing in teenagers. Initially in 2002, 2003, we developed a program. We did an efficacy study with a process evaluation. There was a very promising result. Then we decided to start rolling out the program. We slightly adapted it. We piloted it. We scaled it up. And in the whole of the Netherlands, the program was implemented. And what we saw was that there was only a very, very slight effect compared to the initial positive effects on body composition and behavior. So the 2003-2007 efficacy study showed to be effective, but then the rollout was not. So then the key question is, what happened in practice? Well, everybody was satisfied with the program, and despite their satisfaction, the level of implementation faded away in the 2 years following the rollout. There was some parent involvement, but still only 27% of the teachers finally embedded the program in the school curriculum. So the conclusion here is that physical inactivity is a public health problem. We have got effective interventions at hand who have been proven effective in efficacy studies. They are mainly directed at the individual. At the same time, when rolling out, there's only limited sustained intervention effects. And then adherence and compliance is limited and problematic. Now, this is the other side of the problem. I've spoken about this. Ankle injuries and hamstring injuries. Typically, you would try to test effective interventions in randomized controlled trials. These trials actually show effectiveness. If we jump to the ankle injuries, And we concluded that unsupervised home-based proprioceptive training, in addition to usual care, is effective, and that there was a twofold reduction in ankle sprain recurrences for self-reported ankle injuries and for time loss injuries. They even showed to be cost-effective. We found an incremental savings of the intervention of about 103 euros per injury, and if you multiply this by the number of ankle injuries that are being sustained in the Netherlands per year, you come to actually substantial figures. However, and here I apologize, you can't see the underlying graph, but there was a marked difference in effectiveness compared to those who fully adhered to the intervention as compared to the group who had no adherence. There was about a 37% difference. So here again, the conclusion is that we have highly cost-effective interventions. It should change clinical practice. However, adherence strongly determines outcome. And the same was found if it comes to a review where they looked at neuromuscular training to prevent ACL as well as lateral ankle sprain injuries. And despite the availability of these intervention measures, teams do not seem to implement. And I've already talked about the hamstring issue. Similar problem. Bar actually wrote that the majority of Champion League or Norwegian Premier League football teams do not implement. And another recent review in Clinical Journal of Sports Medicine by Van der Horst also shown that we have an effective intervention, but it's not being adhered to. Now, what I also said, that personal motivation of each stakeholder, and there we already come to a sort of a socio-ecological model, the player, coach, medical staff, knowledge of the program, effectiveness of the prevention program, and consensus between staff members are important. So then the question is, what's going on here? Now, obviously, we are dealing with behavioral change. Now, is behavioral change, is that a matter of self-responsibility and self-regulation? Because if that is the case, I can say, well, Paul Dijkstra, you need to be responsible for your own behavior, become physically active, or start implementing these injury prevention interventions. And Paul can probably do that because he's from a high socioeconomic status, and he's got sufficient financial means to execute these interventions, and he's got sufficient health literacy to actually adhere to the intervention. But my argument is that the lower you get on the socioeconomic ladder, the more difficult self-responsibility and self-regulation becomes. So then the question is, if you look at the broader population, how realistic is the solution of self-regulation and self-responsibility? Now, if you look at the simplest model of the determinants of behavior, first of all, we're dealing with attitude. Attitude is very often associated with knowledge, and it's the personal belief that a certain behavior is beneficial for health. And it's the weighing of the pros and cons of this benefit to health. So I may say, well, I want to be physically active because it improves my health, but I don't want to do it because it makes me sweaty and filthy and stink. Now, obviously, most people have got a positive attitude towards health behavior. This also means that any intervention geared towards improving health behavior by changing attitude is probably not going to be very effective because people already have the right attitude. Then we are dealing with social influence. Social influence refers to social norms, how in a certain society we perceive a certain behavior as being desirable. Here we already have a little bit more leeway to change behavior, but this requires contextual interventions. And then finally, we need to deal with the issue of self-efficacy, which means that there must be a perceived relationship between a certain behavior and the expected outcome. And people must have a high level of self-efficacy, and then there must be sufficient facilitating variables in order to enable that behavior, or there should be a reduction of barriers. Now, my argument is that it's the environment that drives behavior. And this environment has got a broad connotation. It's the physical environment, it's the economical environment, and it's the social cultural environment. Now, obviously, we try to look at this from a very organized and neat perspective. We've got an outer layer of environmental policy measures. We've got social cultural variables. We've got a number of variables linked to the individual, and in the middle you have the actual behavior. And now there, in my opinion, there's ecological evidence that it's primarily the environment, the policy, and the social cultural variables that actually guide a certain behavior, and that interventions geared at the individual variables per se are less effective. Now that is actually very explainable, because if you look at a picture like this, and you don't need to look at the details as such, you can see that we are dealing with a much lesser organized picture than if we look here. So if you pull one string, probably the other string goes down. And what you need to do is you need to have a situation where you create an environment which is conducive of becoming physically more active, or of implementing a sports injury prevention measure. Now, the health professional is dealing with the individual. And from the perspective of the health professional, it's obviously logical that most of the interventions are geared towards this individual. Now, if my argument is that it's questionable if this is effective from a preventative standpoint in the long run, you may also have an alternative model. Obviously, we are all operating in a societal political context. Now, if society, or like I've written down in brackets, politics, would create a system which comes from environmental science, where you would have a situation where there is equal opportunity for all, where you create a situation of environmental justice that will benefit the individual by contextual measures. Now, Michi et al., a couple of years ago, have introduced what they call the behavior change wheel, where in an outer layer you are dealing with these contextual measures. Then in the red we have a number of intervention functions, and then finally in the middle you have the sources of behavioral change, being opportunity, capability, and motivation. And I think we are primarily directing our efforts at the green, and maybe a little bit at the red, but not enough at the gray part of this behavior change wheel. In order to enable ourselves to have a better grip on the gray part of the behavior change wheel, you may want to consider careful design of these kind of complex interventions through a system which is called intervention mapping. And intervention mapping is a protocol that describes a stepwise process for theory and evidence-based intervention of health promotion programs. And you first start by looking at the literature. You then start interacting with your stakeholders at a broad level. And then finally, you co-design with your stakeholders the intervention. And then finally, you introduce these interventions. So you, with intervention mapping, you need to take into account behavioral and environmental determinants also, perhaps on top of any biomedical determinants or elements that you may want to consider, being primarily driven from a medical perspective. So, as I said, the key elements are a literature search, the use and assessment of a theory, and you need to collect environmental data also. Now, from this theory, there is a group of people that are in what is called the Physical Activity Research Collaboration that have recently looked in a qualitative systematic review at barriers and facilitators for implementing community-based physical activity interventions that were actually designed along the lines of this intervention mapping theory. And basically, despite the fact that most of these studies they looked at had been designed in a very neat way, they still could have done better with an a priori implementation plan. So you do not only set up an intervention, you do not only look at effectiveness, but you must have an a priori implementation plan. And what actually struck me most of this paper is that there was a tremendous lack of evidence of the effectiveness of current implementation strategies that actually had applied these conceptual, theoretical starting points. So it seems as if implementation science is still in its infancy years. And then obviously, as researchers, they concluded that further research is needed. Now, this is a slide that actually comes from sit-to-stand desk interventions, where they have tried to look at these 4 different layers of intervention levels, where you have the intervention per se, where you have the implementer, where you have the immediate context where the intervention needs to be implemented, and where you have the broader organizational context. And if you then try to map variables that relate to effective implementation strategies, you come up with facilitating factors like having a healthy working culture, having sufficient financial support, make sure that anyone in the staff is on board, make sure that there's familiarity with the implementation setting, and make sure that all the implementers are implementing along the same lines. Now then, there's obviously also hindering factors like having insufficient information at the start, having late delivery of environmental components, the immediate guidance team or managerial team may also be a hindering factor if they're not along the same lines. Anyway, you can read this for yourself. So we are dealing here with a complex issue, and the complexity has already been demonstrated in this slide before. Now, what I also find important, and in the background you see an up escalator on a railway station in Leiden, and you see that people are gathered on the escalator, and nobody's using the stairs. Now, if it comes to health behavior, you should question yourself whether this kind of up escalator behavior, whether that's abnormal behavior in a normal environment, because in that case I can say, look, Paul, behave yourself normally, or maybe it should be considered as normal behavior in an abnormal environment. Now, if that is the case, if I would tell Paul to behave normally, he would say, I'm already doing this. And I think that in current society, a lot of our behavior is actually completely normal in an otherwise abnormal environment. Now, if that is the case, you should change the environment and not so, and under the assumption that if you change the environment, that the individual will change, and it will be very difficult for an individual to behave differently if you don't change the environment. Now, if we have increasing levels of overweight and obesity, you should question yourself who is responsible for this. Now, maybe the situation you see with this individual in the back is comparable to this. This is a car crash. Now, if you question yourself who is responsible, you rapidly will say, well, it might be the driver, or it's the manufacturer, or it's the traffic system, or maybe it's the urban planner, or it's the alcohol provider. Anyhow, you will start to regulate. You will start to regulate, and you will start to fine people. Now, if the solution to the health behavioral problem is self-regulation, is that so? Or do we need a nanny state? We've been trying to self-regulate in a number of public health domains for decades, and it doesn't lead to a solution. Well, I think that physical activity promotion and sports injury prevention are two sides of the same coin. And I think that self-regulation and self-responsibility obviously plays a role here. But we should change public health by changing politics, and maybe more so than by trying to change the individual. You may also want to argue that if the problems keep on increasing despite all our efforts, we're dealing here with market failure. And if we're dealing with market failure, it's political wisdom, then there's a political responsibility. Now, political solutions to these problems might be that you have imperative health effects evaluations of anything you introduce, or that you provide tax incentives, or that you have stricter health-guided regulations, and that could be in sports medicine or in sports itself. It could be by stricter rules adherence, or by changing the rules. Now, obviously, we have examples in public health where this is shown to be highly effective. John Snow, at the time of cholera, had no idea about the relationship between the bug and the disease because it simply wasn't known. But he did notice that there was a concentration of cholera cases pivoting around the Broad Street pump. Now, he shut down the pump and he terminated the problem. And there's current examples or evidence that this may work. They introduced in the UK a soft drinks industry levy not too long ago, and they've done an analysis of the effect. And the effect was that 1 year after the introduction, the volume of soft drinks purchased did not change. However, the amount of sugar in those drinks was 10% lower per household per week, which is the equivalent of 250 mils of a serving per person per week. Now, this has tremendous significant public health effects. Now, to sum up this, for which I apologize, slightly chaotic start of my talk, but physical inactivity and sports injuries are significant public health problems. The problems are complex. There's multiple variables involved. A lot of our interventions are targeted at the individual, and yes, we should consider those, and they are probably needed. But the context in which these interventions are being executed actually dictates outcome. Now, if that is the case, we should educate any stakeholder involved in these kind of interventions. But for most, I think that we should also become political advocates, because it's not about public health per se. No, public health is not about health, but it's about politics, I would say. Also looking at the time, I'm coming to the end of my presentation. And maybe I may draw your attention to the fact that the Oxford textbook of Children's Sports and Exercise Medicine. The 4th edition is being released in August of this year. Yeah, well, I thank you for your attention.